哦，Frozen，喂，是，好，它是 biopsy，小的多是小的，是不是？就是一个很小的标本嘛。好，OK，谢谢。好，So the first specimen is coming from a very, very young female, 27-year-old, but he had a past history of unusual cancer, which is translocation renal cell carcinoma of left kidney. So this is her pura if ascites. This is her ascites specimen. So actually, the patient has already developed advanced disease, and we've seen prior specimen from the same patient that already show abdominal like metastasis. So this is a very like a scan specimen with only a few cluster of cells. However, when you take a look of these cluster, when we examine the specimen, usually we will first go to the background to see if there is normal reference of the cell. So in this specimen, you can see they are some reactive lymphocytes. So this is the size of the lymphocytes in the background. And then you start to see they are cluster of these atypical cells composed of three-dimensional like arrangement, and the nucleus are much bigger with an open chromatin pattern. So overall, the specimen shows significant drying artifact. However, you can still appreciate that there are some nucleoli and some irregularity of the nuclear membrane. So this is consistent with a metastatic renal cell carcinoma. Usually for the renal cell carcinoma, when we see in the metastatic setting, we will see cell with prominent nucleoli and with abundant cytoplasm, because the most common subtype is clear cell renal cell carcinoma. So usually the cytoplasm will show more abundant, sometimes with vacuole or lipid droplet. But because this case, it is not a clear cell carcinoma, but however, you can still appreciate there are some like a cytoplasm uh, more than usual. So this is consistent with a metastatic renal cell carcinoma. Due to the scan cellularity, so the entire specimen, we only see one foci, which is suspicious for renal cell carcinoma. So we will call this case suspicious for renal cell carcinoma. Then we move to some fine needle aspiration. First, we are looking at US guided aspiration specimen, targeted pancreas mass from a 71-year-old female. So on low power, it is a very cellular specimen, but we all know that in the US guided aspiration, it is very common that we can see some benign, like contaminated mucosa in the background. So this is a benign looking fragments of mucosal epithelium. So we can see that the nucleoli is very uniform, all rounded, and arranged in a very well organized honeycombing pattern. So this is our reference cells. And then we go to the adjacent cell. You can definitely appreciate that the nucleoli are much bigger. The architecture is very complicated, and you need to focus up and down to see clear each level of the nucleus. And the arrangement is disorganized. We see like these irregular glandular pattern. So this is consistent with adenocarcinoma. So the specimen is positive for pancreatic adenocarcinoma. So the next specimen is also a US guided specimen, and it is relatively lower in cellularity. We do see benign element. So this is the goblet cells in the mucosa. So this is consistent with transduodenal. So this is duodenal mucosa. The prior case, we do not see these prominent goblet cell, but this one we are certain that this is transduodenal. So then we start to look for like atypical cell clusters that is diagnostic for adenocarcinoma. So here we have some like three-dimensional cluster, but it is a little bit too thick, so it's not easy to see through. But in the background, we can still appreciate that these like irregular glandular cells, very disorganized arrangement. So when we interpret US guided aspiration, I will usually also check the serine markers as well as the image. So the serine tumor marker CA19-9 is highly elevated, and the image does show mass lesion in the pancreatic head. So this is consistent with an adenocarcinoma. So here we have a better preserved like a fragment. So the cell does show like a more like a well-differentiated feature because we do not see prominent nucleoli in the fragment. However, these cells does show disorganized arrangement. So if you draw a line along the long axis of each of the cells, and you can appreciate that they all crossing with each other. We do not see prominent 1 to 4 polymorphism. We only see this disorganized, so-called drunken honeycombing type of pattern. So whenever I do not see a very prominent polymorphism, I will make sure that the clinical picture is consistent with an adenocarcinoma, which include elevated CA199, as well as a mass lesion by image. So here you can appreciate that the nucleoli, the membranes are highly irregular with abnormal open chromatin, but we do not see prominent nucleoli. So this is consistent with a well-differentiated adenocarcinoma of the pancreas. So the next specimen is also a US guided aspiration, but it is target intra-abdominal mass lesion, uncertain it is originated from which location. So in this specimen, in the background, we do see some inflammatory cells along with some very spindle-looking nuclei. So we see a lot of spindle cell as well as some inflammatory cells. So this is not what we used to, like the most common lesion is epithelial lesion, but it seems to be more like a spindle cell lesion. So we move to a larger fragments. It is cohesive but very thick, difficult to see through, but we still can appreciate there are some spindle cells here and there. So this is, so the most common intra-abdominal spindle cell lesion is actually a GIST. So sometimes a GIST is usually originated from the intestinal wall, but sometimes if it is too big, it is a little bit difficult for image to be certain that where is it located from, originated from. So we do see these type of palisading pattern and spindle cell. So the most common tumor would be GIST. The other tumor that can have this presentation is intestinal schwannoma. Usually a schwannoma is commonly have a lymphocytic coughing. So for this specimen, it's a little bit uncertain whether this is a GIST or this is a schwannoma because we see more than usual lymphocytes in the background. So we will wait for the biopsy. There is a concurrent biopsy and they are doing some stain on these lesions. So we will wait to see what exactly it is. So finally, this is a thyroid aspiration specimen. So the specimen is from our branch hospital, so we only have the direct smear. On low power, the specimen is very bloody. We see a lot of blood, but we do not see uh, like follicular cell, and we do not see colloid. So if this is the specimen, we are going to call this non-diagnostic because it is only blood and very rare cluster of follicular cells. So here is one cluster of follicular cell. And when you take a look of these follicular cell, first is that most of the nucleus are perfectly rounded and uniform. So it is very bland looking. But additionally, we start to appreciate that they are some microfollicular patterns. So it seems to be like aggregates of several microfollicles. So if you see prominent microfollicular pattern without a colloid background, and if it is very bloody, it is highly likely that it is a follicular neoplasm, because follicular neoplasm usually composed of small follicles without prominent colloid, and because usually it's very hypervascular, so it's kind of easy when you do the aspiration, you do aspirate a lot of blood and producing a low cellularity, highly bloody, but with scattered microfollicular type of pattern. So this is actually like a very suspicious for follicular neoplasm. So we will go to an additional smear of the same case. And when we go to the periphery of the slides, and we can see some more microfollicle. So sometimes a very bloody specimen, you still need to pay attention that if you can identify like prominent microfollicular pattern. So here we start to see a bigger aggregates of like a cellular cluster. So in this cluster, most of the cells are stroma, of fibrovascular stroma, and then you can see some detachment of the follicular cells, mostly rounded, arranged in microfollicular pattern. The nucleoli is slightly enlarged. So this is likely to be a RAS positive tumor because the nucleoli does show some like a very subtle nuclear atypia, but without prominent feature of like a PTC-like nucleus. So we are going to sign out this case as suspicious for a follicular neoplasm. So this is kind of a typical presentation of a follicular neoplasm in aspiration because it depends on the operation skill and the size of the needle. And most of the time, you will see a very bloody specimen. So you need to identify these cellular cluster. So this is consistent with the follicular neoplasm. So we are going to sign these out at TBS category 4. So that's for all the case today. 6吗？